on Facebook, and we are celebrating National Nurses Week. I mean, if you've ever been in the hospital, you've ever needed help, you have to love nurses, right? Because they are there for us at our most vulnerable time, and we'll never forget it, really. So this is a time, I think, this next hour to really, if you're thinking about becoming a nurse, if you're wondering what makes nursing so special, if you're thinking about changing a career, we're going to cover 4 very different aspects of nursing within GBMC, and we really want you to get jazzed about this profession because there is so much about it you probably don't know or realize, and it really could be a great option for a lot of people. And we're going to go to like the department that probably is considered by most people the most exciting, ever-changing, dynamic department. Mark Fisher is here. He is a nurse at the emergency department at GBMC. And actually, it's funny because I've been seeing all the nurses who are coming in and talking with us today. I've seen so many letters behind everyone's name. I mean, most people probably have no idea. You are a BSN, an RN, a CEN, a TCRN, right? Like what the heck?
It's called alphabet soup. So when nurses go back to school, first we obtain our college degree, so our bachelor's in science, which is my BSN. Then we take our state exam, which gets our RN. Then after that, there's advancement, so certification. So I'm certified in emergency nursing as well as trauma nursing. So that's what those other 2 credentials are after my name. So my CEN is for my emergency nursing and TCRN for my trauma.
So how often do you go to like a party or just meet new people and you tell them you're an emergency room nurse and they're like, oh my gosh, that must be so cool.
It's like a swarm.
Yeah, right? Because we've all seen the TV shows, right?
Yes.
That's kind of what we think of. How close is that to reality?
Not really reality. They definitely can use those terms in there, but definitely not a reality-based
Can you even
show.
stand to watch them?
Sometimes.
Okay, it's a good soap opera, right? Okay, so let's take you back a little bit and talk about how you thought, gosh, this is what I want to do with my life.
So that was kind of a journey for me. So I always tell when I'm coaching and mentoring nurses that nursing is a journey. And my journey was more of a calling. I didn't know exactly what I wanted to do. I grew up in the fire department. My family is from the fire department. So I was like, I always wanted to give. And I didn't know really how to give back until I actually went into a CNA or Certified Nursing Assistant program and said, wow, this is exactly what I want to do. My journey definitely has gone from, we learned earlier about licensed practical nurses. I was an LPN, and then I went to get my RN, and then I ended up in the emergency department in critical care arena.
So, okay, so the fire department, now I can kind of see the connection there, but with the emergency room, that appealed to you.
It did appeal.
What about it?
The emergency department, nurses wear so many hats in the emergency department. One time we might be a cardiac nurse or we might be an OB nurse, but we have to have a broad knowledge of everything to provide safe and effective care in a rapid and immediate situations.
Yeah, I would think you'd have to even be part psychologist.
At times.
Right.
But we're also caring and compassionate, and we give that back, and that's the big piece.
Is there something about too discerning in a sort of a critical situation, what's more important than something else, and also reacting in a timely, there's no time, you've got to get good, right, and quick.
So emergency nursing, you definitely access your critical thinking skills, and that's something you build as you become a nurse and become exposed to life experiences. And we have to be able to make those decisions in a rapid fashion.
What kind of person, when you meet someone who says, I think I want to be a nurse, and I think I want to work in the emergency room, what do you look for in a potential candidate? What innate qualities?
That's so hard to tell. I call it the spark. There's a drive that you see in someone's eyes. It's like, this is what I want to do. This is how I want to give back. It's just very almost raw type of feeling that you get when you're interviewing someone.
Okay, so we want to focus too on stroke care.
Sure.
Because, and I did not realize this until talking with you, but nurses in the emergency room, at least a lot of them, right, at GBMC, have some extra training when it comes to recognizing the signs because, as I think most of us know, time is of the essence when it comes to stroke and other ailments and illnesses as well, but particularly stroke.
That is correct. Our nurses go each year to get specialized training to make sure that we're able to identify stroke in immediate situation. So if a patient would come in, we're able to identify those signs and symptoms because we know that, like you were saying, that time is what we call time is brain. So the quickest we can get to getting you the care that you need, the more we can save your brain and get you into recovery and getting back to your normal day of living.
So first of all, the person has to make the decision, or someone makes the decision for them, that they need to get to the ER if they think they're having a stroke. So let's start with the symptoms that we might first see in ourselves or someone might first see in us.
Sure. I want to give you all the acronym that we use. It's called BFAST. So BFAST stands for balance or dizziness. Are you experiencing sudden dizziness or your balance is off? E for eyes. Are you having sudden, and that's the key, sudden and rapid change in your vision? F is for facial droop. Is your smile off? Is it not the same as it normally is? A is for your arms. Are your arms drifting, or you're not able to lift your arm? You're having weakness or tingling. S is for speech. Does your speech not sound right? And T, again, for time.
So I've had moments where I felt dizzy all of a sudden, but do you need to have all those kinds of symptoms?
Not necessarily. If you feel that you are not yourself and something is abnormal, I would definitely recommend seeking medical care.
How much time do we have?
So, as I said, time is brain.
Right.
So we really want to get to you as soon as possible. There is a window that American Heart Association has given us guidelines to. So we really like to give intervention within that 4-hour time of onset of symptoms.
So we get to the hospital, we see you. You're the first responder, so to speak, in the hospital. What do you do as a nurse? We're not waiting for the doctor to come. You're looking already at this individual.
That's correct. So when you come into the emergency department, you're greeted by a nurse. The nurse is able to identify you very quickly, and what we do is we activate what we call a stroke alert. This puts everybody on high alert that there's a patient in our emergency department that needs our care right away. There's many steps and initiatives into that practice, and I think it's just a dance that we do to make sure that you're getting to your intervention or your care right away.
So what does that look like? I mean, I've been in the ER, a couple of times with kids especially, but is there an alarm that goes off and you can immediately tell that somebody's getting immediate care? I mean, it's like all hands on deck?
It is all hands on deck, but we do it with such finesse that people really don't know.
Nobody's freaked out.
People really don't know what's actually happening, and we're able to make sure that we keep the patient or the family members calm and informed of what's going on through this process.
So that must be kind of incredible because in that moment, you're saving a life.
That's correct. That is correct.
And what is the goal? We talked about, we were talking in the last hour with John about best practices. And this is the kind of thing about nursing I think that most of the patients don't see. They remember compassionate care, they remember competent care, they remember the personalities of the bedside manner of the nurses, but they don't know what's going on behind the scene when it comes to best practices. So I'm sure there's a protocol, a certain amount of time you have to hit certain milestones within this stroke evaluation. How does that look, and what are the best practices that you use?
So what we call get with the guidelines. So we practice using evidence-based from American Heart Association. So there are certain times that we have to meet as a registered nurse in the emergency department when we're caring for patients with stroke. So it's like getting your CAT scan, getting your blood pressure managed, or if you're a diabetic, make sure your sugar's not abnormal, because that mimics sometimes a sign of a stroke.
Talk about the 45-minute rule within GBMC.
So that 45-minute rule is from the time you hit the door and get to that nurse, by the time that you get therapy. So when I say therapy, there's a medication that we give which helps if there is a clot in your brain, which is what a stroke can be. It can bust that clot up to try to resolve those symptoms that you're having. So that 45-minute is our time frame to do all this care in a safe and effective manner.
Do you recommend, or do most doctors recommend, if you think you're having symptoms of a stroke at home, to take aspirin?
That would be up to the doctor.
Okay, you can't go that.
So if you call 911, they have their own protocols that they follow for first responders, and there are guidelines to that.
So we've talked a lot about stroke, and because that is a particular focus of yours, and you've had the training in it, but so many other things are happening in the ER, right? I mean, I would venture to guess that on any given day, you have absolutely no idea what you're going to be faced with.
Nope, and that's the fun part about being an emergency nurse. So we as ED nurses, and my team is spectacular, we are ready for whatever comes through that door. And that's just the part of being an ED nurse, being able to respond, knowing that you're coming in that emergency, we're there for you. So that's just a big part about being an ED nurse that is fascinating.
So when you are an ED nurse and you have a team, are you on a different sort of level of the team each day? Do you play a different role?
There's many roles in the emergency department. For example, we have the charge nurse, you have a staff nurse, you have people working in triage, which is your intake nurses that are seeing you come in for the first time and identifying your emergencies. And then you have leaders, like Dr. Owano was talking earlier about our PEM model, our professional excellence model. And then you have the nurse manager of the department.
I would imagine that, and this is, again, I go back to like watching a TV show, but there seems to be a sense of family within the ranks of the team, especially in an emergency room situation. I mean, you guys are really in the trenches in some very heightened emotional situations. That must be very rewarding to have sort of colleagues in that fashion.
The camaraderie in the emergency department, we work very closely together. It's every day, every shift. And we build that rapport and we trust upon one another. And I think that's where that family center type of persona comes about. That we have to trust one another as nurses and that we're working together and getting the care that the patients and families need.
Also, there's nothing like experience.
Correct.
There's nothing like, especially for a newbie who's on, in the emergency room department for the first time, to have sort of really experienced people mentoring them.
Yes.
That must play a huge role. And how long does it take you before you finally kind of get your sea legs?
Every nurse is different, and coaching and mentoring is what we in the emergency department do for our new grads. They have, we have a residency program, and they go through that, and they have a preceptor that's working right alongside them, developing their critical thinking skills, their technical skills, so that support is there for new grads that want to become emergency department
They must be
nurses.
incredibly wide-eyed, right? I mean, just
there are
experiencing
moments.
situations for the first time. And I'm sure, too, and that's the beauty of nursing.
Yes.
There's so many avenues with which you can go, right? Sometimes I would imagine you would try one thing and realize maybe this isn't kind of for me, and you would switch it up and change. Or you'd be in some situation where like, this is where I need to be. Do you know when you know?
You know when you know. And like I said, my background, I'm critical care. I was in ICU before I was in emergency department. But once you get there, it's that feeling that you have that's your niche. That's where you know you're giving the most back or the most care to these patients.
Well, if I have to go to the emergency room, I hope to see you. But actually, Mark, I hope to never see you again.
Correct.
In that situation. But it's been so nice talking with you.
Yes.
Thank you so much.
You're
and
welcome.
just shedding a little bit of light on what it's like to be an emergency room nurse. Thanks.
You're welcome. You're welcome.
All right.
Thank you.
We're going to talk to many different nurses today from different areas of GBMC because we want to give you just a really good feel for what it's like in this day and age to be a nurse. And there's probably a lot of misconceptions about it. But our next guest, and we're going to kind of switch it up here, is Lisa Groff. And we're giving you a big hand, Mark.
Thank you,
Yay for
guys.
Mark. And we're looking at some pictures, too, of some nurses at GBMC doing what they do best all around the hospital. And, of course, the most important thing right there is you're looking at nurses at the bedside of a patient is patient care. That's really, really, at the end of the day, what it's all about. So joining us now is Lisa Groff, who is an RN, Director of Women's and Children's Services at GBMC. And I do love the labor and delivery nurses at GBMC. I had 3 children at GBMC.
Wonderful.
And my first, my water broke early. And so my labor was held off, and I was 10 days on bed rest in the labor and delivery area, in the maternity area. And I had a twins room. So I was lucky.
Yeah.
So I had a big
nice
room.
big room.
And I was sort of non-compliant at times. And so the nurses were really great. I mean, I really got to know them. I was literally there for 10 days until we had our son. So, and then he was in NICU for a week, so I've kind of
You've experienced the whole...
kind of gotten the whole thing. So thank you for joining us, and talk about your role at GBMC.
So it's an interesting thing. I'm director of Women's and Children, but I feel like it's been a homecoming for me. I actually started as a labor and delivery nurse, and I was listening as Mark was talking, when you know, you know, and boy, you know, I think people either love it or they really don't like it, but I knew that that's where I wanted to be. But it's a fascinating thing that happens, and maybe, you know, other people like me, you kind of like the challenge of doing something different, but staying within the same area. And that's the beauty of nursing. You know, I've heard Dr. Iwanu talk about it, how you can, you know, kind of morph into other things, but stay in nursing. And that's what's so awesome about it. I started as a labor and delivery nurse, and then I decided I wanted to go back to school for my master's degree. And at GBMC, there's so much support for that. You know, there's tuition reimbursement and there's scholarship, and so, you know, they support you with your time and the finances to do that. And then I had the opportunity to be an educator in labor and delivery, so I could help educate and mentor. And then it kind of morphed into staff development, which was more global and gave me more opportunities. And then I found myself saying yes to an opportunity to go back for my doctorate, which was a really incredible opportunity.
Isn't that exciting?
And all of this happened through, you know, the support of GBMC and the opportunities to say, oh, that sounds like that might be fun, and I could do this, and I could do that. And it took me into a whole different realm of evidence-based practice and innovation, and brought me home, which is what's really nice, back to maternal child health. And so I became the director there about a year and a half ago.
And you've come from the perfect background because you can speak everyone's language. You've been there and done that.
Yes.
And that is the beauty of nursing, too. It is not stagnant. I mean, you can change, you can grow, you can learn, you can develop, you can educate, you can... And also, because I think there's such a need for nurses, nurses are a commodity. And they're treated very well at hospitals who recognize how important they are to the whole system.
Yes, and GBMC does that extremely well. I mean, there's so many opportunities to grow and to stay, but to grow within the organization, and I think that's key.
So, and at GBMC, I mean, it has to be in this area, more women are giving birth at GBMC than any other hospital.
Yeah.
Not to put down any other hospital, but it just is. I mean, it's the place to go. And talk about what makes GBMC's labor, delivery, the nursery, and even postpartum, which I think is interesting to talk about too, which at one point we never talked about, right? So you kind of you have your hands in all of that.
Yes. Yes, and I think we're a little bit different because in listening to the desires of the moms and the families that we serve, we are still a labor and delivery, a postpartum, a nursery. You know, a lot of people are moving to more couple care, but we have our own separate entrance. Moms don't have to go to the emergency room or to the main entrance. They can come straight to us. We see as soon as you're pregnant, if you have an issue, you come to us. So we're our own little mini emergency room. But one of the things that's been kind of unique is that we've kept it separate. So there's, you know, expertise where people are kind of nursery nurses, and then there's people who are postpartum nurses, and that's been by design. But one of the things that we've noticed has been an opportunity is to take a look at how we could work differently to maybe increase the teamwork. So it's not, I don't ever want to say it's siloed. It's, you know, the experts are where they are, but now maybe we can team up and say, okay, we're going to have a nursery nurse and we're going to have a postpartum nurse. Instead of working kind of asynchronously, we're going to work together, and we're going to work with this group of patients so that now, you know, the patients can still have the nursery if they want to have their babies and rest. They can go to the nursery, but they also have a team that's working with them, you know, getting them used to how to care for a baby and how to breastfeed and supporting them, you know, in a very synchronous manner.
We want to give you some time to talk about the pilot program that you're running to promote more teamwork within your department. So this is so important, communication, right? Something we all struggle with, I think, in every business.
Yes.
Really communicating with each other.
Yes.
How is that working?
So it's taken the concept that I just described, and we have this pilot is we have people from newborn nursery and people from postpartum, and we have a nursing support tech who takes care of both, and we're teaming them together to say how could we work differently so that that support is there and we're bringing all the care to the mom. And so however it is that they see that postpartum period going, they have the opportunity to, really learn and spend time. And that communication collaboration, the few people that have piloted it so far, they're the ones who come up with the ideas, and they're the ones who are saying, what if we did this? What if we brought meds out here? What if we did this over here? And it's been really an exciting opportunity for them to be part of that change.
Do you think the postpartum area is a real area of growth that maybe wasn't, you had your baby, you left after, it was always, how many days do I have, right? How many days will insurance pay for me to be here? And then you go, and then it's like, okay.
Yeah.
But now we're thinking more
and
about
it's funny.
more support long term.
Yes, and it's changed a lot because you're speaking of days back when there was limits, and
Sure.
you had to leave, and then that's pendulum has swung a little bit. But it's been a very interesting thing that again, we listen very carefully to the voice of our customers, and there's been a desire after a C-section to actually go home earlier than what we were doing. So there's two mindsets, and we need to meet both. Some would like to stay longer and learn all those things because once you go home, you're on your own. And first-time moms maybe don't necessarily have that comfort level right away. So we have the opportunity to have people stay. But if someone wants to go home, we want to address that, but we also want to do it safely. And so we've developed this wonderful program where if I'm a mom who experienced a C-section and I want to go home in 2 nights, within 2 days, I will have a nurse come to my house to check on me, make sure everything's okay. And within the first 2 weeks, I will be given 4 hours of doula services. So someone can come and help me if, whether it's just to take care of the baby and let me take a nap, or it's to help with breastfeeding, or, something like that. And all that's free to the patient, but it's an opportunity for us to just be sure that that early discharge is a safe discharge.
So it sounds like there's much more collaboration
Yes.
and much more almost personal service on a case-by-case basis. We're going to ask this probably of all the nurses we talk with, but again, if you're thinking about becoming a nurse, if you're thinking, and then you're wondering, well, what kind of nurse do I want to be? What is it about working in the children's area or the labor area or the NICU area what do you look for, or what should someone think about for themselves about why that would appeal to them?
Yeah, and I have to connect with what Mark said earlier. There's a certain passion that isn't something that can be taught. You can teach skills to almost everybody, but that passion and that desire to meet the needs of this new family, those are the things that start to grab at you when you're interviewing people to say, okay, even if they don't have lots of experience. As a matter of fact, we're taking a lot of new graduates, and it's been wonderful. But you're interviewing for that person who has that passion. We also ask that people do share time because it's a great opportunity. I think, Mary Beth, you mentioned people say, oh, okay, that wasn't for me. Because you have this ideal, maybe it's from television.
Who knows? We don't know, right, until you get in there.
And so you give people an opportunity that are thinking about it, come shadow for a while and see what it's really like. And it's an opportunity for both sides to say, hey, this would work for me, and yes, you would be a great addition to the team.
Right. There's a lot you can learn in school, of course, but there is nothing like really training on the job and being there and trying to figure out what is your innate ability and what you are passionate about. And the unique thing about working with children and families is sort of this bringing life into the world. It has this sort of there's this incredible amount of hope, I think, that comes with that. Not that there's not difficulties and great sadness involved in that as well from time to time. It has this, it's a pretty amazing thing.
It is, and you nailed it earlier when you said we see people at the most vulnerable time, and to me childbirth is one of those. It can be the happiest of the happiest, and you want it to go exactly the way that mom and that family would like it to be.
Sure.
Sometimes things don't go that way, and so we need to support and make it the best experience possible.
So we also talked to, and I just, especially in this day and age, and I think with this generation going to school or coming out of school, they're thinking about their life as a whole, and they're really like the idea of flexibility.
Yes.
Is there a job that is any more flexible than nursing? I mean, you really can make your own hours. There's just a great deal of control that you have over how you want your life to look.
Absolutely, and we always laugh because in labor and delivery, it seems all of our nurses get pregnant. I don't know, but it just seems to happen. And that it's huge. Where else can you work full time? You can work part time. You could say, I just want to work weekends, or I just want to work nights, or I just want to work as needed. It's all an opportunity and available to anybody that wants to do that. And I go back a little bit too to the unique things about nursing that Dr. Awanu was talking about. We have some of our new grads that have been very involved in, we hear a lot about evidence-based practice and evidence. From the time a new graduate comes into our residency program, there is an expectation in that year that they do an evidence-based project. And this speaks to the collaboration we were talking about. A new nurse in the newborn nursery and a new nurse in the NICU. We're trying to break down the silos and say we're nurses that take care of babies. It doesn't matter where we work. They collaborated on a project on delayed bathing, and they looked at outcomes, and the outcomes were, if we hold off on that, the temperature stability is better, the glucose stability is better, bonding is better, and the science is there to show that it not only is safer, but then it's more satisfaction for the mom. So this was an awesome opportunity for these grads to be part of change.
Okay, and let's talk about that too, because I think GBMC is in a unique position being a community-based hospital where change can happen at a pace that maybe you would never see at another institution. So here you have two new nurses with a fresh set of eyes, a young set of eyes, looking at things differently and looking at ways of doing things not the way they've always been done. And look what you came up with.
Yeah.
And people were receptive to it.
Yes, it's encouraged. We actually encourage the nurses to, if they say, why do you do it this way? And the answer is, I don't know. Then it's time to get to work. And let's look at what the evidence says, and let's do a project, and let's see if there's a better way to do it, or maybe this is the right way to do it. Absolutely, you are spot on that because GBMC is a standalone, we can make change. And it's very respected. At the end of the graduation at the residency program, there's poster after poster after poster of changes that have occurred just through this new nurse's eyes in every different arena that they work.
Are men getting into your department much? It just seems to me like a female type of.
It very much is, and I can say I only remember once in my career that we had a male in labor and delivery. It was very well received. He was very well received, but he moved on to other places, and we haven't had men. We do have a fair amount of men in the NICU that work. Well, not a fair amount, but comparatively.
Right. Like I remember a time there were none.
Yes,
so.
And in pediatrics as well.
Oh, I could see that.
Yeah.
Yes, definitely. What's one of the greatest challenges facing? And you can be really broad, facing new mothers, facing the birthing process, facing nurses within that community.
The challenges for the mothers or the
anything that you just see that you're like, this is either changing or, for example, internationally you keep hearing that there's still some issues with women giving birth. That there's still a problem, maybe not so much in this country, but as much as we know about it and as natural as the process is supposed to be, mothers are still running into health issues. Is there anything that you see that is either a trend or something that you say, gosh, we just need to deal with this?
Well, it's interesting. I think if you were to ask our nurses, we don't have a lot of people going natural. We do have, and I think the main thing is that women think about what they want that birth experience to be like. And if they share that, those are things that we can support, whether it's I totally want to go natural or I want to have,
right.
some
It's so
assistance.
funny you say that because the New York Times has just come out with a new parenting section, and and they're not using the word natural anymore because they feel like it's divisive.
That's a good point.
For the mothers, right?
Because it sounds like then I had an unnatural delivery.
Right.
Yeah.
Or, you've made a choice
Yeah.
that I don't agree with.
Yeah.
And it's a very interesting way of thinking about personalizing your child. But I think we have a question.
Yeah, and before we get to the question, I just want to say that a lot of people on Facebook have been commenting how much they admire you and they like you and stuff. So there you go, Lisa. I hope you.
Oh, thank you.
Hope that makes you happy. The question has to do with relation with doctors. Is it better? Are we having better lines of communication?
Oh, yeah, we have great relationships with the physicians, and it's interesting because there's been a lot of change even in how physicians are structured. Some of them are now employed by the hospital, and we have in labor and delivery particularly, always a physician on call. So there's advanced practice nurses there 100% of the time, and there's also a faculty that's there to back up. And so that close relationship, when you spend that much time together, is just something that builds naturally.
I think, if you look way back on the history of nursing, and you look 50 years ago, there was definitely a pecking order or a hierarchy within a hospital, right? The doctors were up here, the surgeons, the doctors, everybody stayed in their lanes, right?
Yeah.
It just doesn't even apply anymore, right?
No, and it's fascinating. We've just started doing where the attending physician that I was just speaking about, every morning in a huddle, they will take some fetal monitoring strips and take a look at them to see what can we learn from them together. So it's nurses, advanced practitioners, and the physician all learning together, so that we can make sure that everybody is kind of reading things the same way and communicating the same way, and that collaboration can occur.
Yeah, and if the doctor is receptive, the nurse has so much information to give the doctor about what they're like the feet on the street, right?
Yeah.
They're seeing boots on the ground or what have you. They're seeing the patient. They're knowing the patient. They can spot things probably way before a physician who's coming in and out and doing rounds could see.
Yeah, exactly, because many times when moms are in labor, they're seeing patients in the office,
Sure.
and so the nurses are their eyes and communicate, that communication's pivotal.
Well,
So.
one day I want to witness a birth. Like,
It's one.
I missed my sister-in-law. She had 2 false starts, and I didn't make it to the actual one, and I didn't do the mirror thing. So I didn't want to see my own because I just felt like I'm going to feel it. And if I see it and feel it, it's going to feel much more, that kind of thing. But now I just love it so much. I could listen to birth stories all day long. My husband doesn't get it, but I want to hear all the details. I just love it. It never goes exactly the way you think it's going to go.
But it's
It
always
is this
perfect.
amazing ride. It's an incredible thing.
Yeah, and it never does get old. It was the one thing I worried when I first started labor and delivery, and I remember as a student nurse just crying when I saw my first birth, and I thought, oh, do I want to be a labor and delivery nurse because it might become routine? And it never does.
Really? It never?
Never, ever does. No.
Wow. Thank you so much for joining
you.
us and talking about what you're doing at GBMC and hopefully giving somebody a spark
Yes, I hope.
to want to join you. Thank you.
you.
Lisa Groff, everyone.
Thanks.
And we're going to continue talking about different aspects of nursing. There's so many areas from which to choose. And this one I know is so important to many people who need infusion for various reasons, whether they have low iron in their blood, or they need chemo, or whatever it is. There's so many. It's such a need that there are offices everywhere doing it, and. So Dawn Stefanik is here, and she is a nurse manager at Infusion Therapy. Are you in the main campus of GBMC?
I am on the main campus, and we are in the West Pavilion, so we are outpatient, and we are located in the Cancer Institute.
Okay, let's talk about what you do.
Okay, well,
Big, broad question, right?
I am the nurse manager of the Infusion Center and the Infusion Pharmacy on a daily basis that is hooked. We have a satellite pharmacy there that prepares all the chemotherapy and the IV things that we give. And we are the infusion center for the whole hospital, and we do those types of infusions like you were just talking about, such as iron, or people who have need immunoglobulins to help for infections, antibiotics, et cetera. But really the majority of what we do, probably 90-95%, is related to cancer therapy and cancer treatment.
So you're the main center at the hospital for this.
We
How
are.
big is, I can imagine how many chairs you have? I don't know how you designate that.
So we have 22 chairs. We have
Okay.
grown 2 or 3 times since I've been there in 20 years because we've had the need. So we have 20 chairs in our main infusion center. We also have a few days a week that we go to the Chesapeake Urology site in the North Pavilion. There's an infusion center there. And with new referrals for patients from Chesapeake Urology, we will see those patients there. And the majority of those are cancer as well. And we're actually getting ready to have another infusion center as well. We're broadening out into another area off campus, which will be our first one really off campus, to try to give patients more flexibility and more options, especially when they're undergoing cancer treatment and they have to come back and see us so much.
So much. I mean, sometimes daily, depending on what.
Correct, while trying to live their normal life.
Right, or take care of their kids or what
Right.
have you. So I have known several people who have been in infusion treatments, and there's not a one of them who would not talk about the care of the nursing staff. I mean, it meant the world to them. They are going through all kinds of things, right?
They are.
And not to mention how they feel from the treatment, whether they're having side effects or they need food, or it's just the most caring, supportive, confidence-building environment, they say. What led you to go in this route? Let's just start, backtrack. How did you even think I want to be a nurse, and how did you start that whole process?
Well, honestly, when I graduated from high school, I wanted to be a nurse. I was going to Village Julie at the time.
Yep.
And at the time, they asked me to pick...
Which is now Stevenson.
Stevenson University.
Yes.
So they asked me to pick another program because we were at the time where, prior to the nursing shortage, they would graduate a lot of nurses, they would get out of school, and they couldn't find jobs. So like every 7 years, it was like a roller coaster ride. So they weren't able to find graduates jobs.
Isn't that amazing to you now to hear that they couldn't find jobs?
They couldn't find jobs. Here they are. They've graduated, have school loans, and no way to pay for them. So they steered me into a medical technology program that had all the things that I needed for nursing in case it changed in the future and I wanted to go back. So I did laboratory medicine. So I did that, and I graduated. A couple years later, I ended up working in a lab, and then they were closing, and I was looking for another job. I responded to an ad in the paper, and it was a primary care oncology practice to run their lab. And when I went for the job, the physician, Dr. Gary Cohen at the time, who interviewed me, he said, do you know how to do IVs? Do you know how to do chemotherapy? Do you know how to do portacasts? Do you know how to do chest x-rays? And I'm just sitting there like, no. The ad said for a lab tech to run your lab. And he said, well, are you willing to learn? And I said, are you willing to teach me? He said, yes. I said, yes. He's like, you got the job.
Get out.
So,
Wow.
back in private practice 25 years ago, a lot of times in physician practices, you might have been a physician assistant, in training, or you could be a nursing assistant or a medical technician, and they would train you and you would do these things under their license. They would take responsibility. So that's how I got the job and fell into oncology. And just the relationships that you develop with your patients, it gives the patient satisfaction as they're going through their worst time, and then you see them go through some of their best times.
It's their worst time.
It is.
Life,
They're
right?
very vulnerable. It's so many things going on. And then in addition to that, it gives the nurse in oncology mutual satisfaction, because you can see the results of what you've done with these patients from the beginning, maybe when they were at their worst, and now they're so much better. And with the great treatments that we have today and the continued improvements, people are living, cancer's becoming a chronic disease. So you get that mutual satisfaction.
Yeah, and that's something I don't think we've touched on a whole lot. Obviously, the most important thing is the patient care, but when you're a nurse, you get so much back.
You do, and especially in this field, because these patients are coming to you, like you said, sometimes weekly if they're radiation, and chemo is usually once every 2, 3, or 4 weeks. And then as you see them, and once they get to trust you and their anxiety and the anger and all that associated with the diagnosis has passed, then they develop a trust with you. And, often they will tell us things that they won't tell the physician. They might have just seen the physician and they'll say something to us, or we'll identify something and we'll be like, why didn't you talk to the physician? Well, I don't want to bother them. So they tell us and we intervene. And so they tell us some of their innermost
Yeah, and I would
thoughts,
imagine
secrets.
too that you're kind of treating the whole family.
We
too.
are.
It's not
Yes, we
just-
are.
Because they're often getting rides from a spouse or what
And they have
you.
support people there with them, lots of them.
What do you find, and I want to talk about the Lois Harvey Miller Infusion Center, which is the full name, I guess. What is unique about that infusion center, and how do the nurses, specifically from your group, prepare a patient for starting the whole process of chemotherapy?
So when I first started, 20 years ago, we used to do patient education about their treatment regimen at the chair side. We all noticed that when we're doing that and the patient's getting taught and treated on the same day, they're really not paying attention to us. They just want to get their first treatment over. They're scared. They want to be over and done with it. So we decided as a group, in order for our patients to be better suited and better, knowing what they need to do, what the plan is, who their support people are, et cetera, side effects of drugs, how their treatment regimen is going to be, and we really needed them to pay attention and listen, that we would do it at a 1-hour teach session. So we developed a single 1-hour teach session a few days prior to their treatment starting so that they can give us their individual attention and we can give them our individual attention. And the nurse will sit down with the family, the support person, if they bring, a friend, a family member, somebody who...
Another set of ears.
Another set of ears. We always recommend that because still they're only going to hear probably 20% of what we said, and it's a lot to take in. So we will go over that. We'll go over drugs, side effects, treatment plans, how to manage side effects. We want them to be successful going through their treatment. They're going to be on it for a while, and side effects can make or break somebody if they're not managed appropriately. They may say they don't want treatment anymore, even if it is the best thing for them. So we really do a good job. The nurses there are excellent at education, whether it's the research nurses in the Cancer Institute, the nurse practitioners or the office nurses, and our infusion nurses. So everyone is involved in some way, but the 1-hour teach session usually will have the infusion nurse, and on the same day a nurse practitioner, and also someone from oncology support who's doing some surveys such as a distress screening and also like a dietary screening to see if we need to identify any other challenges a patient may have or financial issues as well.
And is this for every patient has a teach session?
This is for every patient.
Wow. So what have you found from these teach sessions? How has the whole process improved for patients?
Well, we have done surveys, and over the years we have tweaked our teach session based on patient feedback. We also make sure we give them a lot of written information to take home because we know they're not going to remember everything, and we kind of call it their like chemo Bible to take home, keep it, and then go back and reference it when they're having a certain side effect or whatever. It has in there who to call, et cetera. So our patients' feedback has been that we made a scary situation, having that diagnosis of cancer, much more tolerable to them, and it made the whole treatment experience much more pleasant because they felt prepared.
They had knowledge.
They had lots of knowledge.
When you're looking for nurses, and I'm sure that a lot of these answers are going to be similar, but what do you look for, and what should a nurse want to be, or someone who's studying to be a nurse and thinking about what area they'd like to go into? What about your area? What about it appeals to a certain type of nurse?
Well, I can say that oncology is
You fell into it.
I
Lucky
fell
for
into
you,
it,
you loved it,
and I
right?
loved it.
Right.
And even when I went back to get my nursing degree and went through nursing school for my second degree, people said, "You'll pick another field." I said, "I don't think so," and I didn't.
And why did they say that?
Well, because they feel like cancer's depressing.
I knew that. I knew you
Cancer's
were gonna say that.
depressing. It's a doom and gloom kind of place. From the flip side of like labor and delivery with Lisa, who you were just talking to, it's not happy, it's sad. But in the 20 years, I have seen so many changes in cancer care. Our side effect management has gotten much better, the drugs we give for nausea and things like that. And then just our treatments have gotten better over the years as well. So, we make it more tolerable. And it's exciting because it's forever changing. You will never get bored with oncology. There's so much to learn.
And people are talking about cancer now. It's not the unspoken.
No, it's more like chronic disease.
So what kinds of specialties, if you're thinking about becoming an oncology nurse, what do you need to focus on in your education experience?
So in nursing school, you really don't get any type of, quote, oncology. Most people don't. They may go to a unit or do like an externship if that's what they choose. But once you get out, if it's something that you're interested in, they do recommend that you work maybe on an inpatient floor for a year or so and get experience or a couple years. The nurses in the outpatient area, they really work independently. I mean, our docs are across the hall. We collaborate with them. We're great partners. But we're the ones that are there all the time, and we identify things and then go back to the doctor. So we really need somebody who has seen a little bit of taking care of the cancer patient, has experience with drugs and things, so that they're knowledgeable enough to do this independent practice.
Is this advanced certification? Is that kind of along those lines?
So yes, so we have nurses that are certified, but not everyone, but we have made a commitment to having all of our nurses certified. We not only need it for some of our certification or accreditation programs, they want a certain percentage, but we feel that they'll be better prepared as an oncology nurse. They have more knowledge, education and training. They tend to pick up subtleties in patients when they're having infusions and things, or if they're having other types of problems. And then it gives the nurse satisfaction, it gives the patient satisfaction knowing that somebody has this additional board certification and this specialized knowledge of taking care of the cancer patient.
All right, Don, I think we have a comment.
Yeah, this comment is from Sandy Kolzak-Woodring. Sorry if I crucified the name, I do apologize. Oncology encompasses every aspect of the human nature and body system. It is a blessing to be invited into our patients' lives at a very difficult time.
Yes, it is. And Sandy is one of our nurse practitioners in the Cancer Institute.
All right. Thank you. Thank you so much, Dawn, for
You're
joining
welcome.
us
Thank
and
you.
talking about what you do, and thank you for what you do.
Thank you.
Really, when it comes right down to it.
Thank you.
And we have another avenue we're going to explore, and that is sort of how to find all these great nurses, right? How do you find them in an area that where healthcare is such a big industry, where there's a lot of competition for really good people, right? So joining us now is Matt Ayers, who also, is it still fair to say that you are a nurse?
I am.
Okay.
I maintain my active RN license in the state of Maryland.
Okay, and you are the Director of Talent Acquisition. It sounds like you work in TV or something, right?
Yeah. So talent acquisition, yeah, absolutely. So I started out as an associate's degree nurse, like a lot of folks do, and I've been a nurse for nearly 11 years now. And I started off in critical care at the bedside, and I kind of found my way, through nursing, like a lot of the folks in our profession do, and did critical care for like 5 years. Loved the patients, loved the care. A lot of folks spoke to the ability to see the results of your work immediately in patients' lives, and that's extremely rewarding. And few professions can you do that. But as I developed and continued on with my master's education and such through nursing, I got into more population health-based care and really trying to work more on the community side and prevent readmissions and really kind of improve the total health of patients. And then somehow, some way, I found my way into recruitment. Somebody approached me about a job in recruiting. And I didn't really know what recruiting was, but I thought I would try it. It was time for something, change in my career, and I loved it. It was a really unique blend of business and human resources and dialogue and relationship building that I could still use my clinical background to influence. So I find myself here at GBMC as a Director of Talent Acquisition, and my role is really to bring in the talent to the organization that's needed to provide the care across the healthcare system.
And you had mentioned to me earlier that not only the fact that you are a nurse recruiter is not always the case. There are a lot of recruiters out there who are strictly just kind of coming from the business end of it, knowing what they're looking for, but you bring a special gift really to the process in that you can relate to the people you're trying to attract.
Sure, absolutely. I mean, it is Nurses Week. Nursing is absolutely very important and dear to my heart. And there are great nurse recruiters out there that are not nurses. You don't have to be a nurse to practice as a great recruiter. However, having the clinical experience and body of knowledge behind me, I know day to day what it's like to care for patients, the type of profile that we're looking for. I know a good candidate because I've worked with great candidates. They were my colleagues and coworkers at one point, and vice versa, the other end of the spectrum. So it gives you an extra layer of perspective.
Plus, you can also speak their language when you're talking about GBMC and what it's actually like as a nurse to work there.
Correct.
So let's talk about sort of the global issue, and that is everybody needs nurses. GBMC is no exception. and I'm sure you're competing with other health organizations to find the best candidates. How far do you have to go to do that? What efforts are being made to kind of grow them locally? And what are some of the stumbling blocks that still exist?
Sure. So, to your point, we all in healthcare are struggling with the fact that unemployment is at a 50-year low. Labor market is extremely tight. We're dealing with turbulence and disruptions from outside competitors, non-traditional competitors like Amazon and all these other places that traditionally weren't our competitors in the marketplace.
Boy, Amazon they have their hands in everything.
They are into everything. So that's going to continue. So we absolutely struggle with the same issues that every large healthcare system struggles with. And we need great nurses. We're always on the lookout for great nurses because we have a great employer brand. We have a great employer value proposition in GBMC because of the way the organization is positioned, especially in progressive population health and also patient-centered medical home in Maryland. So it's very progressive in the type of care it delivers to the patient. So that resonates with nurses because nurses really, really care about the outcomes of their patients. You've heard multiple testimonies to why it's important to a nurse to be a nurse, why they practice that way.
I also get the sense, too, that GBMC is unique in that
Yes.
Nurses feel they have a voice.
Yes, absolutely. So, as far as nursing is unique at GBMC because, we are, so I think of it from two levels. From a new graduate perspective, there's lots and lots of, it's a great culture. Nursing is highly visible and elevated. We have shared governments. We are very, very good at developing our own and growing our own. And that's really, really important to the newer generations coming into the workforce. They want to be developed and grown. And we do that with our nurse residency program. We actually have our nurse residency program is a year-long, and it's the only ANCC accredited nurse residency program in the state. And it's accredited at the highest level of the ANCC accreditation. So that's really unique. We have a whole team of staff that are dedicated strictly to the development of new graduate nurses as they assimilate into the workplace. On the experienced nurse side, I would say, again, it's the culture and the ability to grow and develop. I think it's kind of an urban myth or a misconception that if you work at a smaller organization, you're not going to have as many opportunities to develop and grow. But that's absolutely not the case. We actually embody the entire care continuum at GBMC Healthcare, and experienced nurses have the same opportunities to grow and develop as they would in a larger healthcare system. And I actually think it's better because of our size. It's a competitive advantage and part of our employer value proposition because those nurses who really identify themselves and show their ethic and their caring, their ability to really interact and dialogue with patients and provide better outcomes actually have a better chance of being visible for that career progression.
Young nurses, are they looking for the flexibility factor the same as they were over the past many years, or what is the thing for them?
Yeah, so again, I think the biggest thing that we see in nursing in the younger generations coming into the workforce is the development. Nursing as a profession, in particular at the bedside, has always kind of had that flexibility available to it because of,
But
we
we'll send you to school, and you can learn
Correct,
this, and you
correct.
can go to learn about business or.
Absolutely. I mean, I'm a great case point. I mean, I've got my master's degree in nursing, and I also have an MBA in healthcare because it is related to the work that I do. And most large healthcare systems will engage their talent. And GBMC is no different. We want to develop and grow our prime employees.
Do you find it's imperative for you to have really strong relationships with the local colleges, or for that matter, regional nursing schools, or is that where you have to kind of get in first? And because that's a problem too, right, in and of itself.
Because that's a competition as well. I mean, you
Right.
can go macro or micro on that. There is no silver bullet to finding talent.
Where are you going to recruit?
But so your digital space, you have to be out in social media, LinkedIn, Twitter, Instagram, Facebook. That's where the younger generations are living, and everybody who's seeking a job looks for a job initially on the web, 95%. So having that great digital presence is really important from an employer brand. The other pieces, but to your point, the universities are the ones who produce these educated, credentialed folks who are eligible for licensure. So yes, absolutely, university relations is a great segment to really break into as well.
What concerns you? We talked a little bit about, somebody mentioned the baby boomer generation. now that people are more comfortable with their monetary situation after '09, '08, they're now thinking about retiring more and more. Are you seeing a drop that you're concerned about? Are you scrambling more to kind of reinforce?
So I would say at the 50,000-foot view, every employer is concerned about the baby boomer generation starting to become more comfortable with retiring. So body to body, we will absolutely have, strong economic projections are showing that we will have enough folks to actually do the work. What concerns me from a nursing perspective is the exodus of that experience that leaves the workforce with the baby boomers, because they have large volumes and decades of patient care experience. One statistic I heard is about 2 million years of nursing experience leaves the workforce every year.
That's scary.
So that is scary. But the key to that is really getting in front of the younger generations and developing them and growing them where they're at, helping them understand their career prospects within our healthcare system. That's something we absolutely excel at GBMC.
While you're out there recruiting, how important is it for somebody to make sure that there are mentors available within the population that may soon retire? And does that connect?
It does.
Your process.
It does. I mean, so at GBMC, it absolutely does. We realize how important it is to actually have, to have that knowledge transfer, and that time. There's nothing that replaces that time with an experienced caregiver and the younger generation coming in. So it is absolutely imperative, and that's something that we have standardized processes, and that nurse residency program absolutely speaks to it.
We were talking about how GBMC celebrates nurses, particularly during this week. Is that a selling point for you when you're talking to potential?
Of course, absolutely. We really do celebrate nursing. I'm relatively new to GBMC, and so tomorrow's our Art of Nursing gala, and that'll be my first experience. But I hear it's just this absolutely wonderful, wonderful thing, and it's really to celebrate nurses. And we have all the time regular events targeted towards nursing.
So will you use that on your digital presence to kind of, I bet you will. John, we have another question?
Yeah, we do. This question is from Barb Stir, and her question is there a bridge program for MS nurses who want to transition to ICU?
A bridge program. So to my knowledge, there's no standardized program in place to move a graduate level nurse to an ICU. However, there's always opportunity to move folks into critical areas of critical care, peri-op. We cross-train folks all the time to move into those roles.
When you're giving your pitch to anyone who's young or not young, whatever, who says, I might think about doing that, I might be interested in that, and you're setting GBMC apart from other places, what are your biggest pickup lines?
Yeah, the elevator pitch. I would say that the biggest thing really does go back to the culture. I've worked for a very large health system in the past, and GBMC is deeply rooted in its community. It cares for its community, and that shows every single day. You walk in the building, everybody says good morning. They say, how are you? Do you need help finding something? Because I obviously look like I always need help finding something. And that really reverberates. It's the culture. It's the thing that really matters. If you love people and you really want to be good at building relationships and making an impact on patients' lives, that's the place to be. You can certainly do that anywhere you practice nursing, but it's really different and unique at GBMC. Of course, we offer competitive, benefits plans, and we have free parking, and we have all the great things that every great employer does. But I think it has to go beyond that. It has to be a feeling of being rewarded and know that your work really matters, and that happens at GBMC. And
this is an era in which young people job hop a lot, and it's not frowned upon. But I get the sense that people stay at GBMC. They do. They do. Our nurses actually, we have an average tenure of about 10 years of nurses at GBMC. And it does it. The win is it's okay to move from job to job, but do it here at GBMC with us. We'll grow you and develop you. We'll expand your career prospects here in our healthcare system. Nursing as a profession is sort of transient. I'm a great example of it. And but you grow and develop and move on every time. And we have a slide up right now that you have walk-in Wednesday interviews.
Yes.
Wow.
So that's actually a brand new initiative we started specific for nursing and nursing support. We are really trying to be innovative and find ways to make it super user friendly for the candidate. Because it's a consumer market right now, and if you're an experienced nurse or experienced tech with a year or more of work experience, walk in every Wednesday in May from 1 p.m. to 3 p.m. and you can sit and speak with a nurse manager and a recruiter without having to apply. Just come in, bring your resume, and we're going.
So walk in where exactly?
Walk into the main lobby. Walk
Okay.
into the main lobby of the hospital. Ask for the recruiter or manager for Walk-In Wednesday, and the front desk will have us come collect you.
All right, Walk-In Wednesday if you're interested. Just thank you so much, Matt, and just thanks to all nurses, past and present, and hopefully future. What you do is so critical for all of us, and it's clearly from the heart, and we are in your debt. Thank you. Thanks for joining us today on Greater Living.